Good afternoon, everyone. We'll go and call this meeting of the Special Committee on Access to Quality Healthcare to order. Thank you all for being here. Thank you for your willingness to hang in here for the brief delay that we ran into with the scheduling. But thank you for being here. We'll go on and get started. We have a bill to present and vote on today. Just as a reminder, as a preface, we have several that are going to speak to the bill. This committee has done some important work. I don't see Dr. Hawkins here today, but one of the main things that was done several years ago was the solution to surprise medical billing. That was one that was a convoluted, difficult issue. Chairman Smith worked on it for a long time, then Chairman Hawkins did, and this committee passed an end to surprise medical billing being a surprise for patients. I think that's been the focus of this committee since its inception, was how do we get access to quality health care for patients? How can we do it in a way that is, respects all the business interests that are in, all the individuals that are the caring people who take care of our patients and our elderly, and so many other ways. We did it last year with a bill that took patients out of the middle when an insurer and a large health system had a disagreement about being in network. So we worked hard to take the patient out of the middle. If you look at House Bill 867, we do have a sub that's out here right now. I want to make sure all the committee members have one. Were we able to, I know we have three online, Chairman Perkle, Representative Fry,
and Chairman Parrish.
And Chairman Parrish. I don't know if we were able to send them the substitute, but if we can do that pretty quickly. So we'll be looking at LC 338953S. And I can tell you the goal of this bill is you've got pharmaceutical manufacturers, you've got PBMs, you have insurers, you have employers who sponsor health plans. What this bill seeks to do is to, once again, take the patient out of the middle when it comes to high cost shares for prescription drugs. We know there's some major advances in prescription drugs. Certainly Pfizer and Moderna and Johnson & Johnson made a big difference in this pandemic. A lot of new medicines coming out for many different conditions, and many of them are the difference between a patient going on disability down the road and being able to continue working. So some of these pharmaceutical miracles, pretty much, are expensive, especially brand name drugs. But a lot of times your family member's physician or your own physician thinks that your life could be made much better or prolonged or whatever by a new medication. What this bill does, 867, essentially assures that patients will only pay the cost share on the true net price of the bill, of the medication. So if we can look, I guess I'll start with the title at the bottom, Truth in Prescription Pricing for Patients. There's a definition on line 19 of a rebate. Many of you have gone to a physician or maybe a surgery center or a hospital, and you've seen a list price out there that might be really high. And believe me, I'm not here to defend all my medical pricing as an ER doctor or a urgent care center or anything else. But there's a kind of a list price out there. Then there's a big contractual discount, sometimes thousands of dollars, many times thousands, even tens of thousands of dollars. And then there's an amount after that that is kind of the real price. That's the negotiated price that a large insurer might have negotiated with a health system or with a surgeon or other care provider, and there'll be a large discount. And basically your 20% copay or your deductible is based on that negotiated price. It's not based on a list price up here. What we've seemed to have allowed to happen in the pharmaceutical industry is that medications get priced at a list price, and that price actually gets paid, but then there's a large rebate. It could be $1,000 a month medicine with a $600 rebate. Well, we all know the true price, according to this bill, if it's signed into law, the true price is $400. What you should have to pay if you're in your deductible period is $400, not $1,000. What you should have to pay if you're in the 20% timing is 20% of $400, not 20% of $1,000. That's really simply what this bill tries to do. It tries to ensure that when PBMs do their work, and they do great work, they negotiate large discounts in the same way many of our insurers, Aetna, United, Cigna, Anthem, negotiate great discounts for surgical procedures or for medical stays in a hospital or any other medical visit. They negotiate big discounts, and that's great. They use their size to help patients and then the patient pays a portion of the negotiated amount after the reduction. What we want to do is really to have parity with that when your constituents, your family members, or you yourself have a particular medical condition that needs a new brand name drug. It can be the difference, but like I say, between continuing to work and pay taxes and support your family or becoming disabled. It can be going in the hospital once every 3 years or twice a year. When you need one of those medicines, we want to make sure we don't want you to get it for free. And that was a problem with an earlier bill, was with refunding the rebate to the patient. We're really not trying to change a plan design where patients have to have sweat equity, if you will, or skin in the game. They have to have something to where they're a participant, just like deductibles in every insurance plan there might be for homeowners or car or anything else. The whole plans are set up to where you have to, the consumer in this case, or patient in this case, has something at risk too. So we don't mind them paying, and we understand that's going to be expensive. Even 20% of some of the new medicines is expensive, but it should be 20% of the true price, and that's defined in the bill. The true price is on line 42. The true net cost is the amount paid or to be paid by the pharmacy benefit manager or health plan client to the pharmacy or dispenser for a prescription drug, and it's less any rebates received or estimated to be received. So that is what the bill does. It just requires that calculation. Many of you know, if you go to pick up a medication, sometimes you're not sure what it will cost. I talked to a fellow representative recently, and the price was zero at the counter for a medication. Really don't know how much it was, but zero is a pretty good place. But basically the computer at the Walgreens, Walmart, Publix pharmacy, independent pharmacy, the computer is set up to recognize all these major plans and their PBMs that do the pharmacy benefit side of the health coverage. And it's a computerized program, and it tells you if you hadn't met your deductible, maybe it's going to say it's $80. If you have met your deductible, maybe it'll say it's $16 because you're having to pay 20%. And maybe if you have a different kind of a plan, it's zero if you've met your out-of-pocket maximum. That's all calculated at the point of sale. We just, according to this bill, if it's signed into law, once again, will require that the patient's out-of-pocket cost share will just be based on the true net cost of the medication. A couple of concessions that we made in this, because we certainly did talk to a lot of different people about it. One of which is that sometimes there are rebates that are negotiated with the manufacturer that are volume based, and you don't really know until part of the year's gone by whether you're going to meet that volume target or if you're going to meet whatever tier it might be. So to allow for the fact that sometimes PBMs, pharmacy benefit managers, negotiate rates with pharmaceutical companies based on volume, and therefore they don't really know whether the rebate is going to be, if it's $1,000 medicine, whether it's going to be $300, $500, or $600. What this allows for in the definition later, where it's called the final net cost, it just allows them, I think at the end of the quarter, with 180 days to calculate it, to true it up later if it turns out the rebate was higher. It allows them to put what they know the rebate will be, the minimum it'll be, and then true it up later. So we wanted that to be a case. We also have plans, because of the desire not to affect premiums. We have a good number of plans, including state health benefits and others, where 100% of the rebate is passed through to the employer if it's an employer-sponsored self-insured plan. In those particular cases, part of the design might be that they use that money that passes through to the plan sponsor, the employer, in this to lower premiums in a different way. So we've exempted those from this bill. So we still think a best practice would be for the patient to pay their percentage based on the true cost, the true net cost. But we're trying to make some progress for patients, and we want to do it in a way that's manageable. Finally, and that would be, by the way, that section is on the last page on line 65, where it doesn't apply if they certify that 100% of the rebates are passed through onto the health plan. So I'm sorry if you got a question, I'd be glad to call on you. If you something I can help with. No. That's the summary. It's a fairly simple bill in a way, but nothing in healthcare is ever really simple. I do think it's our opportunity to continue the progress I think the legislature and the governor has made of a policy of trying to take patients out of the middle when there are, and in this particular case, we tried to save them tremendous out-of-network emergency bills, for example, a few years ago. This is a much smaller savings. This is, you still have to pay your percentage or your deductible, but you'll do it over a true price rather than a pre-rebate price. So I'll be glad to answer any questions that members of the committee have. Push your button, ma'am. We do have some people with PBMs that will speak later, but the pharmaceutical companies generally
The manufacturers.
Well, there's two prices. Remember, there's the price that is the list price, and a lot of times the pharmaceutical manufacturers have to raise that price because they know they're going to have to pay a rebate to get on network with one of the three large PBMs. So the rebate system has become so integral in the pricing that if they know they're going to have to pay a 50% rebate and they need to get $500 per month on a prescription, they're going to have to price it at $1,000 and then send a $500 rebate to the PBM in order to get in network. So in a way, the pharmaceutical company does.
If their medicine's a good product, why do they have to pay for a rebate?
That's the system that's developed with 80% of Americans being covered by 3 PBMs. That's the system that's developed. They shouldn't, you could argue whether they should or shouldn't. We unfortunately don't have any jurisdiction over Massachusetts manufacturers or frankly, Germany or anywhere else that medicines are made. But we can, in this bill, make sure that patients are just paying their cost share based on the true price and not an artificially elevated price that includes a rebate. I'd let somebody else talk to how rebates develop.
But it doesn't seem like that's the true price if we're paying for the rebate on the front end too. We're paying for the manufacturer's rebate cost, and then we're paying for the medicine. Didn't you say they add on the rebate cost to the cost of the medicine?
Well, when they have a new medicine come into market and they have to calculate what they need to get for the medication, the manufacturers have to add on an amount so they know they can pay a rebate to get in network status or on formulary status with the PBM. I didn't make the system up. I'm not trying to defend it. I'm just trying to take the patient out of the middle of all this. But you're right, it's a very confusing system.
But shouldn't the manufacturer charge the PBMs what it actually costs the first time?
You'd have to ask the PBMs about that.
That would make sense.
Instead of a rebate?
Instead of letting us pay for we're paying for the cost of the rebate to start with. Why not just do away with the rebate?
We don't have that authority that I know of.
Okay.
But you're welcome to bring a bill and we'll certainly let people.
And my next question, why are we, I don't understand why excluding all these things like state health benefit.
There was two issues there. There's two potential issues there. We do recognize the executive branch is different than the legislative branch. I will tell you, I've met with them and they have a robust plan that passes through with a outside third-party audit that does pass all the rebates through 100% of them through to the plan sponsor. So there may be a time down the road where we include plans that pass that through as a way to protect patients better. For various reasons, it seemed best on those since the benefit of the rebates, which by the way, the PBMs do a great job of negotiating a great price from the manufacturers. Just unfortunately, it's not always passed either to the plan sponsor or to the patient. We're just making sure the patient's out of pocket with this bill. We're just sticking kind of very narrow, really. We're just dealing with the patient and the part that affects them. The cost portion that affects the patient, we just want there to be transparency with that. Not transparency just for transparency's sake, although a lot of people believe sunshine's the best disinfectant. In this particular case, we're going to limit our intervention or our efforts to the part that hits a patient when they're sick or when their family member is sick. And least able to look out for themselves, we're going to make sure that if they have to pay a percentage or a deductible for a medication, it's based on the true price. And the PBMs know the true price. It's not public knowledge now, but we just want it to be that you can't charge a patient 20% of a number when you know you're getting a significant rebate back on a medication.
Okay. And then so didn't we pass something telling us how these rebates, how much they were getting back? Didn't we pass something about that?
Some of those,
So we know how much money we're talking about.
It hasn't started.
I have no idea how much money we've been talking about.
It can be a significant, we did pass something to try to have disclosure.
A definition. Didn't they have to disclose how much rebates they were getting? No. We didn't pass that.
We've never had a disclosure. The
had a
department's never gotten, that I know of, they've never gotten any summary of the rebates paid.
Did we must just talked about it?
We have talked about it and tried to look into it.
Okay.
I decided to narrow down our focus and just deal with the part that affects the patient's cost.
I just didn't know how much money we were even talking about. I have no clue.
Well, it's hundreds of millions of dollars for some health plans. It's a significant amount of money.
I just had no idea.
And it can make a tremendous difference.
Well, do you have any idea how much money we're talking about?
I can tell you an example. I don't know if we had an example from this morning.
I just wondered how much we're talking about.
On a particular patient or in general?
In general, how much are the total rebates for all three?
I'd have to ask the PBMs if they want to disclose that. It's a great question.
Okay. All right. Thank you.
I did have a. Do you have? Well, I've looked into some health plans, and they, like I say, they could be hundreds of millions of dollars on a large health plan. So it can be a significant amount of money. My understanding, and the PBMs can correct me, but 70 to 80% of medicines are generic, and there are no rebates on those. Then there's some brand names and some specialty drugs are the other two categories where, and I think that was about a third of the expenditure for medicine. So whatever the plan spends on medicine, the rebates might be a third of that amount.
Well, how much are the rebates that state health benefit plan gets?
You can ask the PBMs or the plan sponsor to disclose that, but I don't.
But I'm talking about state health benefit plan.
Well, I don't know if they're here, or if they, I don't want to disclose anything that's confidential.
I didn't know if that, since it was a state agency.
Anybody from DCH? Yes. Hey, Brenda.
The Department of Community Health.
Thank you.
I can certainly ask our SHBP pharmacy team if they can pull that for you and share it with you.
I just
Can you?
wondered.
Yeah.
I mean, but the chairman is right. It is a significant amount of money. And in SHBP, as the chairman said, 100% of those rebates go to the plan. And so since it is a self-insured plan, all of our claims are paid out of the revenues that come in.
Mhm.
So that is what helps the plan control the premium cost. So anytime we look at sort of shifting those rebates and how we have to consider how that's going to affect premiums.
So this doesn't have anything to do with self-insured plans.
I mean, I can't speak to that.
But I mean, a lot of companies have their own self-insured plans.
Two questions real quick. Can you ask if it's okay to disclose?
Yeah, I'll certainly ask that question.
I mean, I know the number. I just don't want to disclose anything that was confidential. So that I'm sorry, I haven't asked if that was
does this in self-insured plans, does this cover self-insured?
The 62% of Georgia families we didn't want to leave out. Certainly there is some Supreme Court decisions, and according to those, this was narrowly written to where it would apply to those families who are insured by an employer-sponsored plan. So it looks like it would, but obviously there's better legal minds than mine.
Okay, I just couldn't tell I'm just somebody from South Georgia. I don't understand.
Yeah, I'm not buying any of that. You played that card before. Thank you, ma'am. Did you, Chairman Knight?
I was going to maybe speak, and this is not to the state health benefit plan, chair lady, but an example within financial statements of a certain company. This is Heron Therapeutics, but it's a note regarding their rebates. This is, again, audited financial reports. But the note is a description of the matter and its product returns. But as discussed in note 5 in the consolidated financial statement, the company earns its revenue through the sale of its products. And this is Vanti and Sustol, I think is the way you pronounce. I'll ask the good physician if I pronounce that correctly. To specialty distributors. Such revenue totaled $88.6 million for the year ended December 31, 2020. The amount of the revenue recognized is net, okay, of the product sales, allowances for the product returns, distributor fees, group purchase organization fees, discounts and rebates, and Medicare rebates, which totaled $119 million. So in essence, they said that the $88 million was their net recognized revenue. They subtracted out $119 million that was made up of basically the larger portion is rebates, but other fees and other fees that are associated with the rebate process. So in this case, the drug, their revenues was $88 million from the two drugs, but they had $119 million that they paid out, majority in rebates and other fees. That's how much this stuff is marked up.
I can give you a patient's example that was sent to me. This was from yesterday by a pharmacist that filled a medication, and he told me the PBM and the medicine. But let's just he had a prescription today he said, I had a prescription today for an expensive brand drug that has a generic equivalent. He told me later it was for a child who had a rare medical condition that has a generic equivalent. The less expensive generic was not covered and was told by the PBM that the brand is covered. The adjudicated price for the brand drug is $4,407.08. The generic equivalent is $1,419. The generic is still expensive, but only the brand name is covered. Why is this? In what realm of business would this happen? We know that there are medicines that have significant rebates in them, but no one will ever disclose those. And I'm not even in this particular bill, I'm not asking, certainly not for individual drugs or manufacturers. We're not asking them to disclose that, or certainly not requiring it. We just want, when the patient's cost share is calculated, they're going to have to use the true price. They can't use, and one of the problems we run into with this situation is that there is a financial incentive for the PBM. If you can imagine that current case of a $4,000 or $1,400 drug, I'm not sure whether they push the brand name on purpose. It does make their company more money. It looks like it does. Maybe it doesn't. Maybe they can give us some examples that prove it doesn't. But it certainly appears, if they're good fiduciaries for their shareholders and they've got a chance to have $2,600, $4,400, $3,000 rebate and a generic that they get nothing on, the system is set up that you could argue would encourage that. So what you're going to hear probably from the other side is that this is going to raise premiums. I would counter and say two things. In the areas where they've already done the 100% pass through of the rebates, we're excluding those. So there should be no reason for premiums to change. On the ones, and the estimate I've seen is 0.6% that it might go up. But we really don't know two different things, how many cases there are when a high price, high rebate drug is preferred over a less costly generic. We don't know because there's no transparency. That could lower premiums. The other thing that could lower premiums is by being more fair to patients at the point of sale. They're more likely to take their medicines and we had people, I know I have a pharmacy tech friend who said that a lady picked up 14 days of her medicine because she couldn't afford the whole month prescription. As we make them more affordable, we think compliance will go up. That may, as I mentioned before, it's better to be in the hospital once every 3 years than twice a year. If that's what taking your medicines on track do, if they help you avoid dialysis, if you take your blood pressure medicine, better compliance can lower premiums. So I think you're going to hear that premiums might go up. There's a significant chance in many people who believe they might go down. We're trying to tailor this narrowly to where it offers the best opportunity for that. And I know we have a question with Representative Bentley on Zoom. Can you hear me? Representative Bentley?
Yes, sir. Good afternoon, Mr. Chairman. I really didn't have a question. I just want to make sure that members from the Department of Community Health know that I need to connect with them and like to do so sometime before the end of this week.
It's one way to get it done. You got a
That's
thumbs
good.
up from the audience. So I
Thank
think
you.
you're getting a contact. I can guarantee you.
Yes, yes.
Thank you for
Thank you,
participating.
Mr. Chairman. Oh, absolutely. Thank you. Good information. Good meeting today.
All right.
Question, but it's always bothered me that the cost of medicine would be so much for somebody that was terminal. And they would say, you know, it's part of its research and everything. Well, the person will be dead before they do the research on it because they can't pay for the price. That's always they say.
We do have some individuals who've signed up, and I do apologize. I know we did make some changes in the bill after a recent meeting to try to make it as fair to everyone as possible, with the primary goal being fair to the patient. So I know you may be seeing it for the first time on some of the changes, but we're going to go on and let's see, we have a presentation online. Is it Robert Levin? Are you there?
Yes, I'm here. Thank you very much.
I appreciate your
really a pleasure
participating
to be
today.
here.
If you could just tell who you work with and then proceed.
Yes, so I want to thank you, Chairman Newman, Vice Chairman Cooper, and the rest of the committee for giving us the opportunity to present in favor of House Bill 867, or the committee substitute. I am Dr. Robert Levin. I am a rheumatologist from Clearwater, Florida. And I've been the president of the Alliance for Transparent and Affordable Prescriptions since its inception in 2017. I am a rheumatologist, and we take care of patients who have autoimmune diseases and complex diseases that are hard to treat. And as you had mentioned during your opening, Mr. Chairman, the patients that we treat really do need some of these expensive specialty medicines, especially to treat the most common autoimmune inflammatory disease that I see is rheumatoid arthritis. After you gotten through the generic drugs, which do work in about 25 to 30% of the patients, you're left with a choice of expensive medicines that oftentimes have list prices over $6,000 a month. And I know in my patients in Clearwater, Florida, and I'm sure most of your constituents are unable to afford that price or their coinsurance, especially when their cost share or their deductibles are based on the list price. And so I'd like to give you a presentation about how that all works and try to answer some of the questions that came up during the beginning part of the session. I've been in practice in rheumatology for 32 years. As I said, I'm the president of this organization. I'm also I've been the president of the Florida Society of Rheumatology, and also I'm on the board of directors of a group called the Coalition of State Rheumatology Organizations, which we're all looking to improve access to care. And I think this bill is very timely. Can I have the next
Levin,
slide?
we do have the presentation in front of us. So for the committee members, if you can try to give us an expedited version so we can
I'll go
make sure everybody has a
can.
chance. Thank you for your work with patients, but go ahead.
Sure. So I just want to explain who our group is. Our group, ATAP, is a coalition of more than 20 patient and provider organizations who work at the federal and state levels. And we were joined together to address pharmacy benefit managers and their impact on prescription drug costs, and most importantly, access to care. And you can see the logos of many of our member organizations, and the Georgia Society of Rheumatology is part of us. Next, please. So who are the PBMs? They've been hired by health plans to manage the prescription drug benefit programs and provide other services pursuant to the negotiated contract. And they are in the center. They act as intermediaries between the health plans, the manufacturers, and pharmacies, and then indirectly the patients. The most important thing, one of the most important things from our perspective, is they develop formularies. And so let me explain a little about what a formulary is. A formulary is a preferred drug list. So let's say we have 10 different drugs to treat rheumatoid arthritis. The PBM is involved in deciding which drugs we use first. Those are first tier drugs, and then second tier drugs. And then there are also drugs that are left off of formularies that are non-covered drugs. And that determines patients' access to drug therapies. So give me the next slide, please. So purely administrative purpose back when they were first formed, but as the costs have continued to rise, PBMs offered the services that promised health plans less expensive drug programs and lowered costs. But the thing is that they've lowered costs, as you mentioned, that they negotiated these rebates, which I'll get into in a second. But the question is, where do those rebates go and where are they retained? And I'll make the contention that much of these rebates and also drug price concessions, which may be not classified as rebates, actually are retained within the PBM and serve as profit. Next, please. So who are the PBMs? You can see the top three, CVS Caremark, Cigna, and United Health Group through OptumRx. They control nearly 80% of the patient's population's covered medications. They're also, these companies are also number 4, 5, and 13 on the Fortune 500. So they are very profitable entities. These companies basically control where things go. Next, please. So this is a complex schematic, and I'm not going to spend much time on it, except I want you to see that the PBMs are in the center. So these companies that control drug access and drug pricing are right in the center. And so we see the manufacturers up at the top of the slide. And so the manufacturers, their whole goal when they have drugs that they want to get on the market is they have to get access to the formulary. And the formulary, as I mentioned, is the preferred drug list that is put together by the PBM. And these formularies really are not based on safety of the medication, on effectiveness of the medicine. They're based on profitability. And I'll get to that in a second. But the bottom line is, how are these drugs profitable to the PBM? Well, the manufacturer sets the list price. And then the PBM, there is a negotiated rebate, and the rebate could include fees, discounts, all price concessions. That's how I would define a rebate. And so all price concessions, and then what we're left with is a net price that the PBM acquires the medication for. And that rebate, which includes all those other factors, are what's retained. Now, the question is, where does those rebate dollars go? Some of them may go to the health plan. What we would like to see, and what would be ideal for my patients, would be that rebate would be applied to the cost of the medication at the pharmacy counter, so that the patients who are the sickest actually are the ones who benefit from these price concessions. Drugs prices are high. I'm not here to be a shill for the manufacturers, nor am I here just to attack the PBMs. But the bottom line is that we know that these prices that the patients are paying their co-insurance on are the list price, the highest price, the price that nobody uses, and are these arbitrarily set prices that the manufacturer sets, but nobody pays it because the PBMs have negotiated these large discounts. And these, we don't know what they are because they're all concealed. They're all confidential. There is no transparency. And so we really have no idea how much these are, but based on the profitability of the rebate system and where these companies are on the Fortune 500, I think you can venture a guess on seeing how much of these dollars are actually retained. Next slide, please. So I just want you to consider this. If you're building a house, look at the right side. You buy a plot of land and you want to build a house, and you're going to hire a contractor. What you're going to do is you're going to get some plans together, and then you're going to bid out the contract to see that, one, you want a quality contractor, but two, you want the best price possible. And so what you're going to choose when you construct that house is considering quality, but what is going to give you the most cost-effective, the lowest price? Well, that is not the system that is set up when drug manufacturers are trying to get a drug onto the formulary. Formulary equals market access. And so what happens is these companies are trying to maximize the rebate. And the rebate, as you can see, is based on the list price, the percentage of discount off that list price, and the market share, or the number of prescriptions filled. And so what you can see right here is rebates will go up if the list price goes up. And that's counterproductive or counterintuitive, or actually just a bad system that's set up for our patients. This, I believe, has been a major driver in the manufacturers increasing their list price. And I can just tell you that several of the manufacturers over the past 5 years have put out transparency reports. And in those transparency reports, what they show is despite increasing list prices, with significant list prices, their net profitability on each unit sold has actually gone down steadily for the past 5 years. And I can name 2 of those manufacturers, Johnson & Johnson, as well as Lilly. Next, please. So this is a graph of insulin prices from 2007 to 2021. And so what you're looking at in blue is the gross cost per patient per year. And what you can see is that we started out at a gross price of, or what the patient was paying off of, $1,567. And by the time Q1 2021 came about, the price was over $6,000. Whereas if you look at the net cost per patient year, in other words, how much of that price was rebated, what you can see here is the rebates really were not much in the first few years, but you can see how much they've grown. And by 2021, you can see that 84% of the, there's been an 84% of the price is actually not the net cost, is the rebated amount. Next. So what we're looking at with this bill, this seeks to disclose the true net and final prescription drug costs and calculate cost sharing requirements for insured based on the true net cost of prescription drugs, provide for remittance of the difference in cost sharing payments by the insured based on the final cost of the drug and not based on the list price of the drug. And Chairman Newman, we really appreciate your example of hospital services and how the insurance industry has negotiated significant discounts off their list prices. And you, as a patient, I've seen on my explanation of benefits that my cost sharing is based on the net price, not off of the list price that the hospital charged for the service, which I think is, we should be setting up the same system for our patients. This really has affected access to care. And many of our patients, especially who have $6,000 a month drugs, just can't afford even their cost sharing of 20%, or their deductible. They'll be out of, even though the drug is approved, the de facto is that they cannot actually access their treatment. So we really need a reduction of, we need to apply the discount, the total amount of discount to the net price and have our patients pay their co-insurance or their deductibles off of the net price, not off the list price. Increase the transparency, prevent PBMs from funneling revenues through third parties to avoid disclosures and pass-throughs, and ultimately save patients dollars and oftentimes life-saving medications. It keeps patients out of the hospital, it keeps them healthier, it keeps them working, and keeps them off of the disability rolls. Next slide, please. So there are other states that have taken action to regulate PBMs and increase transparency. And in West Virginia last year, this bill was passed and signed into law, where there was a 100% rebate pass-through and other PBM reforms. And this was a terrific bill. and a great model to go off of. And you can see, in the interest of time, I won't read the rest of these, but you can see there are many other states that are in the process of reviewing, legislating, and trying to enact new laws to promote PBM transparency and pass through of the rebates to the patients at the pharmacy counter. I also want to mention that federal agencies are trying to establish a uniform definition of price concessions. And that's really what we're looking for. Is we want the patient to have advantage of all of the price concessions that are negotiated by the PBM, whether they're called fees or rebates or whatever. Whatever they're called and whatever structure they are, that percentage, they should all be included and all be helping benefit the patients. Next. So in summary, ITAP urges Georgia House of Representatives to advance House Bill 867. And you can read the last paragraph. All I want to say is thank you for your attention and your time. And I really appreciate the opportunity to speak for you. If you have any questions, I'll be happy to answer them.
Questions from the committee members? Yes, for Dr. Levin, go ahead. Chairman Jones.
Thank you, Dr. Newton. Dr. Levin, can you hear me?
Yes, I can.
All right. The good Lord gave me a radio voice. Real quick, just in really fast machine gun style, because I know Dr. Newton's trying to move the meeting along. Can you go to the graph around pricing, please? The gross and the net.
Sure. Let me.
You don't need to. We have it in front of us, but if you can just direct your attention to that.
Yeah, we're getting it up right now.
A bunch of us on this committee are not as learned as you are. Is it your position that the blue line, which represents the gross costs, that's an artificial inflation because of the desire to be able to provide greater, I'll say, percentage of rebate?
Yes.
Okay,
Exactly.
so, and again, my apologies, I'm not in pharmaceutical. Was there any type of materials cost that would have caused the cost of insulin to go up in 2014 through 2017?
Well, I mean, there was, during that time, there was minimal inflation. So I'm sure labor costs went up and there may have been some other minor cost increases, but inflation back then was really not much.
Right, but sir, that's not my question.
No, the answer is no.
Okay, thank you.
There's no good reason why that the manufacturing price should have gone down. And in fact, a lot of the manufacturers in the products that I use have actually improved their technology and improved their throughput because of better manufacturing plants and better manufacturing techniques, and therefore their costs actually per unit manufactured has gone down.
Dr. Newton, if I promise just 30 seconds and
Sure.
I ask Dr. Levin to keep it to 30 seconds, one more.
Sure.
Thank you.
30 seconds.
Dr. Levin, as quickly as you can, is it your position that the net cost per patient, is that effectively what you believe the net cost per patient for insulin should be? Or you're suggesting the rebate should come off of that net cost?
So I think the patient should be paying their co-insurance, however the insurance is structured, based on the net price, not off of the list price. Just like on my EOB, when I get a hospital service or my wife gets a hospital service, and let's say the mammogram was $250 and they negotiated a price of $100 and we owed 20%, so we paid $20. It should have been off the $100, not off the $250, where we would have had to pay $50 instead.
Thank you, Dr. Levin, and appreciate it. Let's see, Chairman Knight, did you have a?
I appreciate, Dr. Levin, your presentation. You're very right. Your diagrams are there. It's a little more nuanced than even I think your diagram makes it. Two things, I think, yes, the blue line and most everything we do is an artificial list price. Otherwise, everyone who does not take control of the drugs nor buys them has to have a commission. And that's how they get paid. That's how the PBMs and the other companies get paid, is to take a percentage of a list price off. And you are correct, the rebates are there, but the problem has always been the definition of what is rebates versus other contractual fees and expenses that are in these contracts that no one can see. So I appreciate your presentation. Also, Dr. Levin, I want to let you know that Georgia has been working on the bills. In fact, we were one of the first states, the first state to do anti-steering in the nation back in 19 and 20. So we are working on that and leading the way in regards to anti-steering and transparency and reporting.
Thank you. We're going to move on to some of our presenters. Jesse Wethington, are you ready? Just tell us who you're representing, and I know we did see through I think in Dr. Levin's presentation, sometimes the health insurance is also either owned or owned by a PBM.
Yes, sir. Thank you, Mr. Chairman, members of the committee. My name is Jesse Wethington. I'm the president of the Georgia Association of Health Plans. And we appreciate the opportunity to come and speak with you about some of our concerns around House Bill 867. I'd like to go ahead and start by thanking the chairman for the direction that we've seen in the substitute. Appreciate you sharing that with us prior to the hearing. So we're still kind of digesting some of the things that have changed, but they seem to be generally positive based off the meeting that we had. So I want to recognize that. Absolutely.
You're done.
If I could, Mr. Chairman, we had a couple more
keep going.
things
Excuse me.
we wanted to raise to y'all's attention. And so controlling rising drug costs is a laudable goal. We certainly share that. Unfortunately, we do think that there are some provisions still even in the substitute that may be at cross purposes to that. So that's what I wanted to direct my attention and comments to you today. We wanted to share with the members of the committee that we do think there will be an impact on premiums, which will be negative for ratepayers. Again, for those that are still within the scope of this bill, acknowledging that the no spread plans have been taken out. Additionally, there could be some impacts to health savings accounts that are paired with high deductible health plans. This has come up in other jurisdictions. There's an IRS circular from the state of Indiana or Illinois around that we've discussed with you and shared with some of the members as well. I can get into that detail later if the committee so chooses. So we've had a couple of our carrier members look at this from what the impact would be to their premiums. So I've
not the sub, just the original bill.
The original bill, yes, sir. And so one medium-sized plan has calculated they would see a increase of about $10 to $11 per member per month. For a family of four, that would be $400 to $480 higher premiums in a year that they would pay.
Do you know if that's a plan that has a pass-through, 100% pass-through, or any pass-through?
That would probably be for the non-pass-through plans, but I would like to.
That's one where the PBM keeps the rebate?
Yeah, let me check with that plan because I want to be absolutely certain of that.
Okay.
It wasn't part of the calculation because that wasn't in the bill initially when they did this. But I will verify that and let you know,
Thank you.
Chairman. And they also estimated that only about 15.5% of the covered lives, members they have in a given year on a plan would benefit from a point of sale rebate. And that's because not everybody makes use of the pharmaceutical part of their benefits every year. Some people don't go to the hospital in a year. Some people don't have a lot of prescription drug costs or, spend a lot of time at the physician's office. A larger plan with many more members ran this similar calculation based off the original bill. They estimated that it would be a $23 per member per month impact in terms of higher premiums. So for a typical family of four, that would be about $1,100 per year.
The larger plans are the ones more likely to have what State Health Benefits does, which is a pass-through of the rebates, correct?
It really depends on the customer base. Again, if you're including the self-insured market, that's pretty different than we're traditionally used to talking about here. It really would be across the board and dependent upon what that plan sponsor wants. But typically bigger the pool, they tend to be self-funded as a general rule.
So you can find out if those examples are ones where the PBM keeps the rebate or whether
Yes.
it passes through to the
Yeah, absolutely.
plan sponsor.
We'll rerun this with
Thank you.
subsection D taken into account. There'll also be some administrative costs of this that, we haven't calculated through in the per member per month cost. But again, I think some of those have been addressed by giving us a little bit more time to adjudicate this in the back end. So we certainly appreciate the extra time up to 180 days. Just writ large and kind of where as health plans, our issues with this is you are sort of choosing those folks who are using the pharmacy benefit and pooling, these additional discounts and rebates to those folks at the point of use. What we have traditionally done in the industry is that we take the entire rebate and subtract that against the whole cost of that pool and then give everybody the discount off of that premium. And so, it makes sense if you're going to take part of that and give it to, the folks who are using this at the pharmacy counter. We're no longer able to apply the whole discount for that rebate to the whole group premium. And so for that 15 or so %, they will benefit, stand to benefit quite a bit, but at the expense of everybody else who will be paying a slightly higher rate. Additionally, as we have talked about many issues relating to PBMs, pharmacy benefits over the years in this committee, we would always prefer a bill like this to be in the form of an offering that we would be required to give rather than restricting options in terms of what products we can offer to either our commercially insured, fully insured market or those self-funded plans or employers that are coming to us for these plans. So that would be additional consideration we would ask for you as you consider this moving forward through the process.
All right. Thank you. One question, Chairman Knight.
Thank you to my friend. We had a conversation yesterday.
Yes, sir, Mr. Chairman.
And as your presentation is, y'all are stating from the industry, and I assume that you're representing these PBMs, basically all of these PBMs here. I assume that that's what your health.
So our 8 members, we have the 3 that are large integrated PBMs. We have some that don't have PBMs.
Who are they? Do you mind me asking?
So that would be Optum, ESI, Cigna, and CVS Aetna,
Okay.
Which are members as health plans in our association. There are some members who do not have integrated PBMs and buy services through them.
Well, let me ask you, and again, this goes back to Dr. Levin's presentation. Thank you for what you did, Dr. Levin, when I mentioned that there was another step in here. And again, the comments and the explanations have is that the PBMs are negotiating with the manufacturer. May I ask you if the PBMs are directly negotiating with the manufacturer, or is there an intermediary that's doing that?
Typically, you see them involved in direct negotiations. I certainly don't want to speak for the PBMs, and they're here to speak for themselves. The group purchasing organizations were mentioned earlier in your comments. The wholesalers are involved as well. And so there are other intermediaries in the chain, both on the reimbursement side from the plan.
Well, we're not talking about the reimbursement. This is a negotiating. And as I read from, a set of financial statements, and again, this is relatively new within the last years, we're understanding more of the subsidiaries and more of the companies that are up under these. As you said, Dr. Levin, you quite eloquently pointed out, as I did about 3 years ago, these are some of the world's largest publicly traded companies. But what has happened is that there are general purchasing organizations in which there are intermediaries that these companies have now put one more intermediary between the PBM and the pharmaceutical, the manufacturers. And, it's debatable if they're adding value or if it's one more attempt to be less transparent and hide fees. I'll wrap up with this. CVS created Zinc, which is their general purchasing organization. There's several, like Anthem, I believe, is tied with CVS through that purchasing organization. You mentioned Cigna, CVS, but that's Ascent. By the way, that's a company that was put in and is based in Switzerland, as well as United Healthcare, Optum Rx. I think it just came out very recently as MSR, if I'm pronouncing that right, Pharmacy Service. It is the general purchasing organization there in Ireland. Quite frankly, this is just another intermediary that is negotiating. And again, what is the question of, are you avoiding United States taxes, and are you avoiding regulation in the United States, and thus perhaps in the state, as you take and put one more complicated entity in between into the process. Quite frankly, taxes and fees that they're charging is just one more layer that is coming off of those negotiated prices in which the rebates, or however they're defined, discounts, fees are doing. In addition to this, to the PBMs, one last question or a couple of questions. And I know I got to go.
Sorry.
My chairman is getting on to me, but you mentioned reimbursements, both on the prescription drug side and the hospital side. I'd like a direct answer to a question. Where are the rebates going when it's on the healthcare side? In other words, when you go to a hospital or a doctor's office and there are drugs used, are those rebates coming back? How?
So you're referring to if we negotiate a price concession with a hospital.
No, it's you're negotiating a price overall for the drug, but if it's on your health benefit side, how is it being handled versus on the prescription benefit side?
Got you. If there's a drug that's being paid out through the medical benefit, like it's an injectable or in the physician's
Yeah.
office, how does that happen? Honestly, Chairman, I'm not prepared to answer your question.
And where do
today.
those rebates go?
I think that they probably would be handled separately in terms of negotiation, but that is me speculating at this point, and I really don't want to do that any further. I think
Well-
one of my colleagues, can we shed any light on that on the specialty drug side or? Yeah, let me do some homework and get back to you.
Okay. Well, I appreciate, Chairman, I know you got to go. I appreciate this bill because what it's doing is trying to bring transparency to a process that we're trying to still ask questions and get down to what is the true cost and hopefully bring that relief back to the people in which it's supposed to be for, and that's the beneficiaries.
I do think so. Thank you. I know you referenced this was Dr. Levin's slide. We saw the complex nature of the rebate system and the drug pricing. Frankly, medical care in general can be complicated. That's why I'm a simple ER doctor. I need to keep it simple. We're just sticking with the part where it hits the patient in the pocketbook. The rest of it, we assume that 3 companies that cover 80% of the market, pharmaceutical manufacturers who are sometimes international, often international companies, we're not deciding to try to limit whether they go to Switzerland or Ireland. We're not doing that much in this bill. We're just trying to limit just the impact that it has on the patient's pocketbook when they're sick. And you're right. A lot of us don't use medicines at all until we do. And frankly, that's the same thing as could be said for oncology care. Only 15% of the people, or cardiac care or orthopedic care, pediatric care. All of them are small in themselves. It doesn't mean we ought to treat them unfairly though, and make them pay more so that everybody else can have a lower premium and have them pay 20% of, say, the list price for an obstetrical delivery. Nobody would think that's fair, even though you're right. It may raise premiums. We may disagree. I think 0.6%, you think maybe more. I think we've gotten rid of those, though, the higher ones. But there is a sense of fairness in this as well, that just because a patient's condition requires a brand name medication, I mean, a doctor has to agree to begin with and write the prescription, study the literature, make the decision, and then the patient has to pay. I still think we ought to treat them fairly. Nobody's asking them to get off for free. We just want them to be based on the truth. And we're not going to try to solve all the other subsidiary questions and all. Not in this bill. There may be others, but thank you.
Certainly, Mr. Chairman. Thank you, members of the committee.
Whitney
Appreciate it.
Griggs, could you come up and introduce yourself? Are you, please? I thank you all for bearing with me on the timing of this. I do think this is an important issue that affects so many patients that it's worth our time. So thank you, members of the committee.
Absolutely. And I will try to keep this as brief as possible. My name is Whitney Griggs. I am the health policy analyst with Georgians for a Healthy Future. And GHF is a consumer-focused policy and advocacy organization. And at our heart, we want to ensure that all Georgians have access to quality, affordable health care. So when it comes to PBMs and prescription drugs in general, our perspective is that consumers should be paying the lowest price possible for their prescription drugs, period. As Chairman Newton mentioned, prescription drugs are often the most effective way to manage a condition, but they're also the most cost-effective way to manage a condition. But even moderately priced drugs can put a strain on consumers. We worked on a study last year with Alterum Consulting that found that 38% of Georgians either skip recommended doses, don't fill a prescription, or cut their pills in half due to the cost of prescription drugs. The most important cost by a long shot for consumers is the cost at the point of sale. Rebates and reimbursements after the fact are much less helpful than discounts costs up front. And the primary stated purpose of PBMs is to save consumers money. So consumers should fully benefit from the rebates that PBMs negotiate with drug manufacturers. I do want to add that it's important to us that all Georgia consumers are covered and have access to affordable prescription drugs, including, our hardworking teachers and state employees. But we do support the bill and efforts to meaningfully lower drug prices. Thank you so much.
Thank you very much. And thank you for being to the point. I appreciate that. Bethany, Shara? Oh. Thank you for being here today. Good to see you.
Thank you for having me. I'm Bethany Scher with the Medical Association of Georgia. I just want to say that we support every time increasing transparency for patients at the pharmacy counter and ensuring that patients have the access to the medications that they need. So thank you for your work on this. And we really appreciate this entire committee looking at this very important issue.
Thank you, ma'am.
Thank you.
Michael Power.
Hey, good afternoon, Mr. Chairman, members of the committee. My name is Michael Power. I am with PCMA. We are representing the PBMs. I do appreciate you bringing this bill to this committee, to this legislature. The role of a PBM is—
You're done too.
I should have saved that till the very last, right? The role of the PBM is to help reduce costs of prescription drugs in the marketplace for the consumers. All right, we've talked about that. I think we've heard a couple of folks even raise that point voluntarily on their own. Some things that were thrown out there by Dr. Levin and others, though, I think that we needed to address. One thing in House Bill 946, Section 6 of the bill does require reporting of rebates to the plan sponsors. Their first reports are due July 1st, 2022 of this year. So we're in the process of completing those reports, but I do want to make it known.
Are you going to do those to ERISA plans too? Or do you know?
If the plan sponsor requests that information, we do.
Oh, they have to request it.
It's something that they're allowed to request.
Okay,
Absolutely.
gotcha.
100%. And sort of like, how rebates are used. There's been a lot of conversation today about the PBMs pocket the rebates. The plan sponsor has the choice on how those rebates are used. They can use those rebates to lower out-of-pocket costs for all of their covered lives. And we have to remember insurance is a risk pool. So when healthy people are not taking medications, they are helping subsidize the medications of those who are sick and in need. And trust me, I take that near and dear to heart. Cancer has ravaged my family. I get colonoscopies already. I'm not even 40. I'm going to have my third this year. So I respect it. I respect the need and the balance in the marketplace. The plan sponsors can also use those rebates now to pass that on to the sick people, to people who are taking those drugs if they want. And as this bill does contemplate, and as it was asked earlier, will this apply to the self-insured marketplace? Well, the self-insured marketplace is an employer who voluntarily provides insurance to their employees at their own cost. They may choose to use that rebate to help reduce their out-of-pocket costs on the coverage, the health insurance coverage that they do provide voluntarily in this country.
Is that the rebates that they're passed through to the plan sponsor?
If that is part of their negotiated contract, yes.
Okay.
And so there's a variety of contracting options out there.
So they're
There are some that
excluded
have—
from this bill though now.
If you got for the self-insured marketplace, I think the way the last paragraph is written is that it would be 100% passed through to the health plan, but it would be a mandated option, right? So the client couldn't choose how they wanted to use the rebate.
Okay.
So, we did want to point out there is some transparency coming. 946 did a lot. Chairman Knight's bill was one of the first in the Southeast. It was sweeping reform on PBMs. It allowed, managed plan options or mandated plan options. So PBMs had to ensure that we provided options to our clients, that we weren't keeping things behind their backs and we weren't stealing from them. We would encourage this committee to offer a mandated plan option on these rebates, so that we have to make sure that this is clear in writing, that this is an option for the plan sponsors to choose, and the plan sponsor can do that. Last thing I will point out, Dr. Levin had some slides. One of the slides on, I think it was insulin drugs, came from a drug channels report. There was actually a recent drug channels report that showed that drug manufacturers are reducing their list price, but they're reducing their list. They used to increase their list price by 15, 20%. Now it's like 10, 11%. And the net price is decreasing at a smaller rate as well. So they are still in the middle making more money as they sell these drugs. The other thing that Dr. Levin mentioned was the Janssen and I think it was Eli Lilly report. If you look at those reports closely on how the rebates are provided in the system, the drug manufacturers actually provide those rebates not only to the PBM, They also provide rebates to the manufacturer. If a hospital has a pharmacy, they provide a rebate there. So if rebates are what is causing list price to rise, then we need to look at all rebates in the system. And I'm not talking about the 340B program. That's something totally different, but I'm talking about rebates that they do provide in the system that would also ultimately also drive up that list price. Lastly, I just blanked. There was a lot covered in this meeting. Chairman Knight, you mentioned some other purchasing groups that negotiate with the manufacturers or wholesalers. There is a big group. It's called a Pharmacy Service Administrative Organization. The 3 largest PSAOs are actually owned by companies that have a higher top 10 listing in the NADAC than we do: McKesson, Cardinal, and AmerisourceBergen. These groups formed to negotiate on behalf of the independent pharmacists, to negotiate deals with the wholesalers. I think if you actually talk directly to the independent pharmacists, maybe not the association, but you would find that their PSAO relationship is actually causing as much or more grief than PBMs are today. And so I would encourage this legislature to look into the PSAO space. Since PBMs are already heavily regulated in Georgia, PSAOs are not. So I'll conclude my questions or my comments and be happy to take any questions.
Thank you very much.
Thank you.
Melissa Rival. Thank you for being here.
Thank you, Chairman. This is my first time.
Oh, welcome.
So I am Melissa Rybold. I am with the Georgia Pharmacy Association. I'm the Vice President of Public Policy. And I want to thank you for being here. And I just want to say that we are in support of this bill. Anything that increases transparency and reduces patient costs at the counter. And so thank you for your hard work on this. And Georgia Pharmacy Association thanks you. And we are in support. Thank you so much.
Thank you very much. And Greg Rybold could tell us. Just tell us who you represent and proceed.
Thank you, Mr. Chairman. And is this, I had a few slides. Frankly, I think I'm going to skip most of them, but I do up to you.
Open the laptop.
Is this a laptop? No, I'm kidding.
It's, for the rest of the audience, this is the last presenter today. So thank you for.
This is a thing. I can forget it.
Just hold it. Perfect. So they're going to let you in. Basically, just open your presentation, share it like your screen, like it's your home laptop. That makes sense. So go ahead and open that. Right, there
Slideshow.
we go. Just start turning the computer audio.
Good.
Do it for every meeting, got it. And then go up to the top, or sorry, go to the bottom, hit share screen, and just do it like your own.
Okay, well, My apologies for the delay, Mr.
No,
Chairman.
thank you. Sorry, we had a little late start. Go ahead.
Yeah, and really appreciate the opportunity to offer comment. My name is Greg Reibold with American Pharmacy Cooperative, and we have about 1,800 independent pharmacies across the country with well over 200 here in Georgia. So this is a strong suit. You know, this bill is not a pharmacy bill, right? This is not a
Correct.
win for independent pharmacy. This is not a win for chain pharmacy. This bill is about patients. And so I think it's fitting that it's here in this committee, access to quality healthcare, because I think what this bill is about is that very thing. It's about access to quality healthcare. There've been a lot of really good questions today, and this is a tough issue. And so I'm going to move really, really quickly here. But, you know, obviously the role of rebates and prescription drug pricing has gotten a lot of attention, as well it should. They have far-reaching implications well beyond this bill. Prescription drug list prices, which we've talked about, plan costs, beneficiary costs, prescription drug plan formularies, a lot of different issues. They even factor into patient steering and some of these other practices. So sweeping impacts do drug rebates have in the healthcare chain, particularly in the prescription drug world. And they've largely been hidden, right? It's hard to get at rebates. Why? Trade secrets, open records, you know, they take the position that they're confidential, trade secret, you can't get at them for state contracts. And so it's really hard to know what's going on. Are patients paying the right price? Aren't they paying the right price? Always a lot of questions here. The good news is that the black box has been opened, I would say, at least a little bit. And so the Grassley-Widen insulin report came out a couple of years ago, and it was a bipartisan committee, and they did a lot of good work. It was a 2-year investigation, more than 100,000 pages. They got documents from drug makers, from PBMs, Express Scripts, CVS, Optum, and they got a lot of detail about rebates and the role that rebates play in drug prices. And so just very quick examples of the growth in rebates from, so here's one, Novo Nordisk insulin pen, and you see 2014 to 2019, there's a 52% rise in rebates for that drug. There's another one, Eli Lilly's Humalog, 64% rise in 4 years. And this is coming from that Widen Grassley insulin report. There's another one here, 70% WAC price increase. So, you know, huge increases when you're kind of look at sort of 2012, 2014 into the 2019 range. Rebates were growing exponentially. At the same time, what you see is as these rebates are growing, so as the list prices are going, so too are the rebates. And so here you've got rebates from 2 to 4% in 2013, and they're all the way up to 56% in 2018. Similarly, in 2017, rebates are 47% increase from 2014. So what you see is there is this absolute connection between the growth of rebates and the rise in list prices. And the report sort of conclusively determines that there's this link. And so why are the drug manufacturers paying rebates? And theoretically, pharmacy benefit managers are in the position to negotiate discounts via rebates to get on formularies. And again, we could spend hours talking about, and I think Dr. Levin gave some great examples of drugs that should be accessible to patients and they're not, because ultimately PBMs in their role as pharmacy benefit managers are setting restrictive formularies. And so if manufacturers want their drugs to be accessed by members of these plans, they pay up. And unfortunately, that's the world we live in. Are rebates a good thing? There were some great questions about that. I would note, interestingly, the Trump administration had an executive order removing the federal safe harbor, doing away with rebates, right? They wanted to do away with rebates as a safe harbor under the anti-kickback statute. That resulted in a lawsuit by PCMA. And so PCMA, I think, certainly likes to take the position that, hey, go look at the manufacturers when you're talking about rebates, but they're the ones that sued the United States government, okay? And so clearly they've got a pretty strong interest in protecting these rebates. Now, the question is, are they going to the plans? Are they keeping them? And we're not going to figure that out probably here, but there's a group called 46 Brooklyn that does amazing work on drug transparency. And they took some of the data from that Grassley-Widen report, and I think they created a powerful infographic. And so again, 46 Brooklyn, the CEO is Antonio Chacha, and they've got just a top rate team. But Lantus, 79% rebate in the commercial market. And so what they did is they sort of took that and gamed that out just to see what it looks like. And so we're not talking about plans paying. We're not talking about health plans paying for these sick patients, right? This is, if you look at sort of when they're in their deductible phase, January, February, March, April, the patient is paying $408 for insulin. And there's a $339 rebate. The plan isn't paying a dime. There's a $339 rebate. With your bill, the patient would be paying $69 instead of $408, right? $69 is the cost that patient should be paying.
Under the definition of true net price.
Under the definition of true net price. And how important is that, right? I mean, when you talk about insulin, and by the way, that Grassley-Widen report focused on insulin, but this isn't just insulin. These are patients who are on specialty medications, other chronic brand name medications, and these are sick patients who are oftentimes going without drugs at the counter. They're going without drugs because they can't afford $408. Well, guess what? In any other world, $408 is false pricing, right? The patient is supposed to be paying a percentage of the cost of the drug. Well, here, the plan didn't pay anything. And in fact, they got $339. The patient is being deprived the benefit of the discount. And to the extent that pharmacy benefit managers claim that they're in a position to lower cost, that they're there to be patient advocates, to look out for patients. But here they are advocating against a bill that it's really simple, right? Don't falsify the price. Let a patient pay a copay, cost share, based on the actual cost of the drug, not an inflated cost. This really shouldn't be that hard conceptually. And I'm going to move here. But so this bill doesn't require plans to pay more. And I'll go back, right? It lets plans keep their rebates, but during the deductible phase, the patient isn't being exploited. The proposed bill doesn't prohibit plans from keeping rebates. It gives patients the benefit of the rebates when calculating the cost share. So I want to talk a little bit about impact of plan costs. My good friend, colleague, Jesse Wethington, made a couple of, I think, comments for sort of smaller plans, and correct me if I'm wrong, around a $400 to $480 increase premium across the board, and for larger plans, an $1,100 per year. Other than Dr. Levin and some of the patient groups, right? When you hear PCMA and you hear the insurers, what you don't hear a lot about is the impact to the patient. What you're looking at is this very, very narrow, hey, this is going to increase premiums, right? Will it increase premiums? It might. I'm not going to sit here and say it wasn't, but here's a really interesting thing. There's a CVS white paper, and it's a prescription for better diabetes management. And if you look at the first bullet point, and this is them, research shows that improving adherence by removing high deductibles also enables payers to eliminate out-of-pocket costs for treatments for diabetes and still save money. So what they're saying is, hey, when you improve adherence, costs can go down. They then say research shows that eliminating out-of-pocket costs for members improves adherence, right? So it's kind of a miraculous thing because you don't hear them talking about that. You hear them talking about the sky is falling, premiums are going to go up $1,100 per year, $480 per year. But here's CVS saying a very different thing, and it's not rare. It's rare that you'll probably see me up here agreeing with CVS, and so let's all take note of that. I think it's a special occasion, but this is coming from CVS's own white paper. And look, are there increased costs? Yes. What this plan is proposing to do is have zero cost share for insulin for patients, right? The plan absorbs all the cost. Your bill doesn't even do that, right? Your bill just says, let them get the benefit of the rebate. Let them get the benefit of the discount. But here, according to their calculations, and this is diabetes is where some of the most action is on rebates. According to their calculations, and this is CVS, so I don't know where my friend and colleague, Jesse Wethington, got which plan, but they say, hey, if you eliminate the patient's cost share, it's going to go up $244. And then when the patient's more adherent, that increases some cost too. So it's going to go up $51. But here's the thing. If you stop doing brand over generic mandates and you start buying generics, which your plan doesn't mandate, but it would make sense, $170 savings when you move away from the brand names into the generics. And here's the amazing part. When patients can afford their drugs, they take their drugs. And that increases compliance and it reduces other costs. And so here you've got CVS acknowledging medical savings from increased adherence to $156 per member per year. And so pre-rebate world, $1,256. Post, when you do away with patient cost shares, You increase adherence, you buy smarter generics, guess what? This saves money. This is CVS's own document saying this saves money, but somehow the bill gets introduced and all of a sudden we've got $1,100 extra cost a year for a big plan, $400 to $480 for a small plan. That sure looks a lot different than this to me. And so, you know, what your bill does in sum is gives patients the benefit of the discount. It does away with false pricing. And we've got PBMs, according to their own assessments and records, acknowledging that when deductibles are lower, patients who are struggling to afford their medications can afford them, their adherence is better, and you get better health outcomes. So by putting the patient first, which is what you're doing, there's a good chance that you're going to decrease cost of plans. And so again, I've not seen the records that they're citing to. I don't know how they arrived at their calculations, but I think CVS did a pretty dang good job of making the argument for you that by giving patients the benefit of the discount, you're going to increase adherence and improve outcomes for patients and potentially save costs to the plans. And so I'm happy to answer any questions, but with that, conclude. I know folks probably want to get to a vote, but APCI is strongly in support of this for the sole purpose that this is going to increase patient adherence, increase prices, decrease prices at the counter for patients, and potentially save money for plans. That's good policy.
Any questions? I know I thank you for, in particular, a couple of things you mentioned. You pointed out that this does not help a chain pharmacist, an independent pharmacist. It in no way really impacts their bottom line. There may be problems with the way PBMs and PSAOs and pharmacy companies and pharmacy chains, there may be things that need to be worked out. I think you pointed out, though, this is not the bill to do that. This bill is much narrower. It simply, it doesn't try to solve every problem at every step in that complicated algorithm we saw. It does attempt, as you say, to pass that great work the PBMs do of negotiating lower prices. It actually passes the value of that benefit that they've obtained to the patient at the point of sale, increase in adherence. I think I'm looking forward to them joining with us on this one because I think they can prove that they're in favor of patients and patients paying the lowest cost possible and improving adherence. So we'll look forward to that maybe as we go along.
Thank you, Mr. Chairman.
But thank you for being here. Yes, sir. You would like to be recognized? Sure. Chairman Knight.
Chairman, make a motion to pass to substitute House Bill, my glasses on, 867 LC 338953S. Make sure I got that right.
You got it right. Thank you. We have a motion. We have a motion and a second. Is there any other discussion among the committee or anybody online with the committee? See no other questions. All in favor, aye. All opposed, no. The bill passes. Thank you very much for your time. Thank you to those in the audience for being here. We're adjourned.